Today we will discuss about normal labor. Normal labor is such an important topic from theory point of view that you can never expect a question paper without some components of normal labor, possibly in essay and most likely in short notes. Apart from the importance in theory exam, it is such an important topic that any doctor should possess the skill of conducting normal labor anywhere with as minimal requirement as possible as per the WHO guidelines. And during your internship in the primary healthcare centers, in community medicine posting as well as in the obstetric ward, you are supposed to conduct normal delivery first by assisting, then by individually doing under supervision. Along with that, normal labor is an important long case, which is the de facto long case for every student during the obstetrics final practical exams. So labor is a coordinated physiological process by which a fetus, placenta and membranes are expelled from uterus at that term. It occurs between 37 to 42 weeks of gestation. Although labor is spontaneous and natural, its safe completion requires the harmonious interaction of uterine contractions, maternal pelvis, and the fetus. So normal labor is defined as spontaneous onset and progressive process of uterine contraction leading to cervical effacement and dilatation, followed by expulsion of the fetus, placenta and membranes through the natural birth canal, occurring between 37 and 42 completed weeks, with the fetus presenting at vertex and completed without any maternal or fetal complications. The onset of normal labor is usually spontaneous uterine contractions. Gestational period is 37 to 42 weeks. Presentation vertex, which is left occipito anterior, is the most common. Course is progressive dilatation and expulsion, and outcome is no maternal or fetal complication. So this is the summary of the previously held long paragraph. Coming to the physiology of labor. Labor begins due to the interaction between maternal, fetal and placental factors. The uterine factors include increased myometrial oxytocin receptors, enhanced gap junction formation. Fetal factors include a rise in the fetal cortisol and pressure of fetal head. Cervical changes include collagen remodeling and increased water content. These collectively initiate effective uterine contractions. So the key changes include increase in oxytocin receptors with coordinated contractions. In the fetal level, there will be increase in cortisol production. This will result in head pressure, stimulates the reflexes. In cervical, there will be softening, thinning and effacement. Mechanism of labor. The mechanism refers to the cardinal movements undertaken by the fetal head to adapt to the maternal pelvis. It is described as cephalic, vertex and LOA presentation. First is engagement. The biparietal diameter enters the pelvic inlet, occurs before labor in primigravida and during labor in multigravida. Next is descent. It is continuous downward movement due to uterine contractions, intrauterine pressure and maternal bearing down effects. Next is flexion. The fetal chin moves towards the chest and presenting diameter changes from occipitofrontal to suboccipitobregmatic, that is the smallest possible diameter, followed by internal rotation. The occiput rotates anteriorly from transverse to antero-posterior diameter of the pelvis, allowing optimal alignment of delivery. The next part is crowning. Here, the bipyramidal diameter remains visible between the contractions and does not recede. It indicates imminent head delivery, followed by extension. Here, the fetal head extends beneath the pubic symphysis and the occiput, vertex, forehead, face and chin deliver sequentially. Then restitution. After delivery of the child, it rotates to realign with the fetal shoulders, followed by external rotation. Here, the shoulders rotate to align with the anteroposterior diameter of the outlet and the head follows this movement externally. Finally, there will be expulsion, wherein the anterior shoulder delivers under the pubic arch, followed by the posterior shoulder and rest of the body. So, the cardinal movements include engagement, wherein the biparietal diameter enters the pelvic outlet, followed by descent, continuous downward movement of the head with flexion, presenting diameter changes to suboccipitobregmatic, followed by internal rotation, where occiput rotates anteriorly towards symphysis, crowning. Head visible without any recession and extension. Head extends under the pubic arch and delivers. Followed by restitution, where the head rotates to align with the shoulders, and external rotation, where shoulders rotate to AP diameter of the outlet. Expulsion, wherein the delivery of the shoulders and the body is complete. So here the flood is floating before the engagement, then followed by that there will be descent where there will be engagement flexion, then the further descent there will be an internal rotation and complex rotation with beginning of extension, followed by complete extension where the face, chin and others will come out, followed by external rotation and delivery of the anterior shoulder first and delivery of the posterior shoulder next. So there are four stages of labor. The first stage include onset of true labor pains to the full dilatation of cervix, followed by second stage wherein there will it will start with the full dilatation of cervix to the delivery of fetus. In the third stage there will be delivery of baby to expulsion of placenta. In the fourth stage there will be first hour of the postpartum is considered as the fourth stage of labor. Coming to the management of first stage of labor. Admission assessment. First, confirm whether it is true labor pain by checking the cervical dilatation, regular contractions show ruptured membranes, followed by maternal vitals monitoring and obstetric examination, and fetal assessment of lie presentation, position, and fetal heart rate, followed by vaginal examination at admission, though it is not to be frequently performed. And we have to plot a partograph to monitor and track the process, wherein the fetal heart rate for every 30 minutes with 120 beats to 160 beats per minute, and in contractions frequency, duration and intensity has to be monitored, maternal vitals for every 2 to 4 hours, and maintain hydration and empty bladder. Supportive care includes encourage mobilization, upright position, providing emotional support, and analgesics like opioids, nitrous oxide, epidural only if very much indicated. Okay, interventions include amyotomy only when required and avoid unnecessary vaginal examination as discussed previously. Coming to the management of second stage of labor, first monitor fetal heart rate every 5 minutes and observe descent, maternal effort as well as crowning. Conduct of delivery here, position the mother appropriately, that is lithotomy and supported with a strict asepsis protocol, supporting the perineum by modified Ridgen's maneuver, and deliver the head slowly and controlled, and check and manage the nuchal cord, assist the delivery of shoulders by gentle traction and suction only if needed. Warm and dry the baby immediately after delivery, delayed cord clamping of 1 to 3 minutes with a skin to skin contact, and initiate breastfeeding preferably within half an hour if it is normal delivery, and up to a maximum of 4 hours if it is cesarean section. Management of third stage of labor. Active management is suggested here. Here, the third stage carries the highest risk of postpartum hemorrhage. So, active management of third stage is crucial to reduce the PPH by nearly 60%. It consists of three essential components. First is administration of uterotonic, controlled cord traction, and uterine massage after placental delivery. So, administration of uterotonic. Here, the timing. Give within the first minute after delivery of the child after ruling out a second fetus, and the drug of choice is oxytocin 10 units IM. Alternatives include misoprostol 600 microgram orally or ergometrin 0.2 mg IM, and it is contraindicated in hypertension complicating pregnancy. The physiological role includes it produces strong sustained uterine contractions, compress the uterine vessels and reduce the blood loss, facilitates placental separation, and this single step significantly reduces the risk of uterine atony. Controlled cord traction performed using branded Andrews maneuver. Here, one hand stabilizes the uterus suprapubically, the other hand applies controlled downward traction of the cord. When placenta descends, the traction is directed upward and outward to complete the delivery. The purpose is to shorten the third stage, reduce retained placenta, prevents uterine inversion, minimize blood loss. Precautions: conduct only during uterine contractions and avoid any excessive force here. Uterine massage after the placental delivery. First, palpate and massage the uterine fundus. Ensure uterus becomes firm, contracted and central, and it prevents uterine atony, which is the most common cause of PPH, maintains hemostasis and reduced postpartum bleeding. Continuous monitoring include assessing uterine tone every 15 minutes to 1 hour. So to summarize, in uterotonic, oxytocin is given 10 units IM within 1 minute. It prevents uterine atony, PPH, and facilitates placental separation. Alternatives are misoprostol and ergometrin, and used only when oxytocin is unavailable. Controlled cord traction stabilizes uterus, upright traction during contraction, shortens third stage, prevents retained placenta and inversion. Uterine massage the fundus after placental delivery, ensures firm contraction and prevents atony. Delayed cord clamping for 1 to 3 minutes improves the neonatal iron and hemoglobin. Examination of placenta is mandatory because it detects any missing cotyledons or membranes. Inspect the genital tract to identify and repair any tears. The fourth stage of labor is the first hour of the immediate postpartum, and here vitals monitoring every 15 minutes, palpate the uterine tone, check the vaginal bleeding, ensure bladder emptying. Maternal care include repair episiotomy tears, initiate breastfeeding, and provide analgesia and reassurance. Normal labor is a physiological process that occurs between 37 and 42 weeks of gestation, characterized by progressive uterine contraction, cervical effacement, dilatation that ultimately leads to the expulsion of fetus, placenta, and membranes. The mechanism of labor follows a predictable sequence of cardinal movements that enable the fetus to navigate the maternal pelvis efficiently. These include engagement, descent, flexion, internal rotation, crowning, extension, restitution, external rotation, and expulsion of the fetus finally. Proper management during the first and second stages help ensure safe outcome of both the mother and the child. Here, fetal monitoring, maternal support, aseptic delivery techniques, and immediate newborn care are included. The third stage poses the highest risk of postpartum hemorrhage, making active management of third stage of labor very essential. It involves administration of oxytocin, controlled contraction, uterine massage, delayed cord clamping, and examination of placenta and genital tract. The fourth stage requires monitoring of vitals, uterine tone, and bleeding. When all stages are managed well, normal labor manages and progresses very safely. I hope you have learned through this presentation. Thank you for watching.